Hi, the following content is for educational purposes only and does not constitute medical advice. If you are a healthcare provider, please consult with your affiliated institution or local ethics committee for ethical guidance related to clinical practice. Thank you.
Hello, BioE 131. Welcome to Module 40, Brain-Computer Interfaces with David Magnus.
Okay, and we're going to be talking about ethical issues in brain-computer interfaces, and you've already seen the definition and some of the things that you can do with those sorts of things. So Eric Racine, who is a former postdoc here at Stanford at my center, who does neuroethics in Montreal, his group published a nice scoping review of the literature up through 2017. So what I'm going to be talking about here is heavily influenced by his scoping review, but update a little bit with some of the literature that's been published in the last few years and a few examples that come out of that. So, and maybe a few modifications, but it's based on pretty much on that. So what are the ethical issues that arise in BCI? First set of issues, and by now you should start to be getting a flavor of how to think about these kinds of issues. So unsurprisingly, the first kinds of issues are around safety and risk-benefit analysis. So, so questions like how safe are the devices? Some of the devices, for example, the ones you learned about in the technical briefing, it requires surgery to the brain. So there's surgical risks of infection. There's the risk that you could produce brain trauma. In addition to the risks of the actual procedure when you're doing something surgical, there could be potential for risks associated even with non-surgical interventions with BCI as a result of brain plasticity and the fact that you're targeting changes in the brain. And so when you change the brain, there could be unintended consequences to those brain changes. We'll talk about some of those when we talk about authenticity, but just as an example, which we'll come back to, in deep brain stimulation, hypersexualization is one of the side effects. And so there can be all kinds of other sorts of things that happen, even that have nothing to do with the actual surgery itself. A lot of these BCIs for really debilitating disease require regular training, which can be very burdensome, both physically and financially. And then, of course, there's always the risks of what happens if the tech fails at an inopportune time. If somebody is using BCI to control their wheelchair and it stops in the middle of the street, that would be bad. Right. And so you think about all those risks, and then what do we do if we think about this from a utilitarian framework? We weigh them against all the incredible potential benefits of the technology and all the ways in which it can help people, and you sort of give this analysis of the risks versus benefits. And that's sort of the first ethics take, is to sort of think about the risks versus benefits. That's the free version of the ethics app.
Yeah. But now if you want to get Kantian, we're going to have to
get to Kantian
Ethics Pro.
Now we have to move on to Ethics Pro. What are some of the other ethical issues raised but beyond just those issues? So first set of issues are around they're very broad, around humanity and personhood. So to what extent do we think of some of these devices as tools versus being an actual part of the person? And then part of this, so that's one big set of issues, and we'll talk about why that's important in a minute. Another set of issues are around the potential for using these kinds of technologies, not for pathologies, but for enhancement. And we already saw last time about some of the debates about enhancement, but that's a really, really big issue. A related issue to the issue of enhancement is the issue about what it means to be human at a fundamental level when you start making these technologies. On the one hand, part of me thinks, I'll just say, if I could just, I have a pretty good memory, so I remember most things that I read or lectures that I've seen like forever. But it would be awesome to be able to just download things into your brain and to do all those things. But people worry that when you do that, it will change human nature and may make us less human. Many critics of enhancement and who are worried about this kind of concern have either explicit or implicit views of human nature and what it means to be human. And so hidden sometimes behind these debates about enhancement or whether we're risking alienating ourselves from human nature is a view about what human nature really is. People who have a fairly narrow view of human nature and think that, this is what we are and we can't muck with it too much, are very worried about these technologies. People who tend to think that human beings have a more expansive view about what it means to be human, and that the adaptability and the ability to adapt and change is a very important part of their view about human nature, are less concerned and maybe even welcoming of things that would change things for the better. And as we talked about last time, enhancement, it's normal for people when they get old to not be able to see very well, but Russ and I both have these little devices at the end of on our faces, at the end on the top of our noses, that make it possible for us to see better. And that seems like a good thing. And is it just is it a slippery slope, or is it just a logical extension to things that make it possible for us to remember more and think better and clearer and do other sorts of things with these different technologies? At a more specific level, people are worried about the way in which these technologies and mucking around with the brain may change who we are and how we relate to other people. Right? I already mentioned that there are technologies that make somebody hypersexualized. There are other reported cases where DBS or other sorts of interventions in the brain with things like BCI wind up changing people's personalities in pretty fundamental ways. People suddenly there was an example of somebody who suddenly became a gambler and gambled away all of his family's money in one of the readings you had for today. And then when they turned it off, it was only then that he recognized that what he did was wrong. There's a terrific play that was written by one of my former postdocs. She wrote it, and it was performed here at Stanford a few years ago. Now she's a professor at University of Wisconsin. Her name is Carola Kreitmeyer.
And we've read some stuff by her previously.
Yeah, that's right. You've read a couple of articles by Carola. But she wrote a great play called Homo Ex Machina. And it was about somebody who had this a very world famous scientist. She was an ornithologist who had that severe debilitating disease that was making her increasingly aphasic and difficult to communicate, and make it impossible for her to work. And she had a close a partner who she lived with, who she loved, and then she got a device that made it possible for her to go back to being able to think and work and articulate things, but it wound up systemically changing her personality in all kinds of different ways. And so the things that people are debating, the diseases themselves change us in fundamental ways. This person went from being an ornithologist and a scientist to becoming somebody who is disabled and required help from other people, and was deteriorating and degenerating in different ways. And then as a result of the technology, she went back to being able to do some of those things, but she became more extroverted. She became different in her personality, and she went from being somebody whose object of affection and devotion to her partner she became hypersexualized. So she wound up having a partner of the opposite sex rather than the same-sex partners she'd always had in the past. And all these things changed with who she was as a result of the technology that was introduced into the brain. And so people worry a lot about those kinds of changes and what they really mean for our sense of who we are and our identity. Which decisions are really authentically us? Who is us? Who's the real person? Is it is this tech now who we really are? Is it now part of us? And now I'm a gambler. I didn't used to be a gambler, and now suddenly I'm a gambler, or is it something else? So anyway, so it's so those issues about authenticity and what counts as really us matters.
This is almost an unfair question, but as in an ethical course, if somebody presents these as something that's very important to them, how do you have this discussion? So right away, you're out of consequentialism.
Correct.
And so what's the best way to have this discussion? Do you kind of agree? Do you look for shared basic rights that you agree on and then try to reason through them? Because it just strikes me as it would, if you don't wind up valuing this argument, I'm trying to figure out how you would have a discussion and do trade-offs and stuff like that.
Yeah, I think the issue about it's interesting. You could cash this out either in utilitarian or deontological terms, right? So it's one of the consequences of the technology that the person will be changed in important ways,
right?
And that could have negative consequences, right? It could ruin your relationships. The person who gambled away all their money. It can be great in some ways. Issues about the more deontological part is like, is it really you anymore?
Right.
Is hard to put your hands around in the same way. And either that bothers you or it doesn't. As I said, implicitly in a lot of these kinds of arguments are in fact visions about what human nature is. And then you have to kind of drill down to that. And it's like, if you think this is what human nature is,
All right.
then we're
Yeah.
no worries, then we're stuck. And if you, because I don't think that's what human nature is, and it may
Exactly.
be that that's partly where that could turn out to be an irresolvable difference. And that's
That-
often
that's what I'm
smuggled.
sensing, and that's
Yeah.
why I asked.
And often that's smuggled in. If you look at the Leon Cass Commission for during the Bush administration and their report where they were basically criticizing enhancement, it was called Beyond Therapy. They never talk about human nature, but implicit in everything that they write is an assumption about what human nature really is like, that they kind of dance around in different ways, but it's absolutely what the driving force behind those.
Right.
The
And so if you're a good
transhumanists,
ethicist, you would call them on that because it would not lead to useful conversation to have that be a huge hidden assumption.
I tend to think of it in terms of arguments and where they're coming from, and you're articulating the underlying premises of their argument. So their starting point is here. The transhumanists have such a radically different starting point. There's no meeting of the minds there because their starting points are very, very different. I would also add one other thing in response to all this is to remember that for patients who are locked in, it may make it possible for them to better express who they are. Because it's hard to imagine something much worse. So patients with advanced Parkinson's who are locked in, for those patients being able to find a way to interact with the world and communicate the world in a way that is currently not available to them. Some patients with advanced SMA, although there's now treatments obviously for that, all of those are things that are good things about this, and not just in terms of the consequentialist view, but also good in terms of being able to express who they are and be authentically who themselves in ways that the disease may make it hard for them to do. Okay, next set of issues are concerns about stigma and normality and what it means to be normal. So there's a worry that individuals will want BCI due to disability stigma. And that BCI researchers, it's often an assumption when you look at the researchers that the disabled have relatively low quality of life and that BCI represents improvements. And if that view becomes widespread, that may actually increase stigma. And so a lot of people in the disability community are worried that BCI may actually make things worse for the disabled rather than better. And they're also worried about, and it may lead us to look for a tech fix rather than for a social change, right? So rather than figure out how to create buildings that are wheelchair accessible and make sure all spaces are wheelchair accessible, if you could just put something, implant something into somebody's spinal cord that then runs up into something in their brain so that they could then walk again, that may lead people away from thinking about the social conditions that actually give rise to the problems in the first place. And then it also relates to what does it mean for someone to have normal functioning anyway. And it is pretty amazing how many people with disabilities, when you look over time after they've adjusted, the vast majority of them, their baseline assessments of quality of life more or less return to where they were at the start. And this has led for some folks in the disability community to really argue that what counts as normal needs to be broadened rather than technologically fixed. And you can see this with one potentially, I guess it's a BCI, debate over cochlear implants. Which the deaf community, a lot of people in the deaf community are very opposed to the use of cochlear implants as a way of treating deafness because they see themselves as normal and just part of a different culture. And they see this technological fix that people who develop cochlear implants and who push them think of as a technological fix to something that that's a disability. They see it as something that's an assault on their culture. And so, so those are really challenging, again, very, very different perspectives that again go back to views about what it means to be normal, which is irredeemably a normative judgment. And we see this all the time in these kinds of debates. So next set of issues, autonomy and responsibility, mainstream deontological views. This is a really tough one because if BCI plays a role in decision making. So you're using something in your brain to help you make decision and to think about things in a sort of hybrid math fashion. Is the person solely responsible for the decision? And there's evidence of cases where people who are using BCIs think that they autonomously caused something, but it turned out it was really not in their control and was a product of their device.
Do you have an example of that?
I don't. I've read about this in the summary of the literature, but I don't know what that example is.
They think that they caused something, but the device caused it.
Yeah, I think actually some of the examples, I know that there are similar illustrations from some of the things with speaking. So some of the devices that make it possible to articulate words, and what especially makes that possible is that increasingly, and this has been that development that's really post that scoping review, people are now using AI to supplement those signals, because the signals are kind of messy. It may be hard to figure out. It also may be too slow to be able to work in real time. So you use AI to kind of fill in the gaps, and then it allows you to communicate and act and do your will. But a lot of what's driving it is the AI making a judgment about what you're trying to say and what you're really willing to do. And so there are cases where it's really the AI that's actually doing most of the work, not the person, but they may not be even aware.
Yeah, that's a good example, because I work in this field enough to know that you can give the beginning of a sentence, and if it's an idiomatic sentence, the AI will finish it. And then if it's something similar to an idiomatic sentence, it might still try to finish it, and it may or may not have been your intent.
Right. And again, you may not be able to figure out whether or not it was really you or not. Anyway, so there are different views about issues about responsibility associated with this, including legal responsibility. Some people say, look, if you're using this, it's part of you and you're using it, then you're responsible for its use, even if it winds up doing something that you don't intend to do or wouldn't want to happen. If the AI goes out of control and starts like cursing at people based on what you say and think, what you think, and it accidentally says something that you wouldn't have wanted to say or do something you wouldn't have wanted to do, you're responsible for that, just like you're responsible for the actions of your dog, or you're responsible for the act of your young children. It's an extension of you in the same way that your dog or your children might be, and you have responsibilities for keeping it under control and making sure that it's used responsibly. So you would be responsible on that view. Others say, no, you don't have any individual responsibility. If it winds up working in ways that are contrary to what your intentions were, that's a function of a problem with the device itself. And the people who are ultimately responsible for that then would be the device's manufacturer. And the analogy there would be it's like a malfunctioning car. If your car wasn't built right, and so it winds up having certain kinds of systematic accidents, that's not your fault. That's the fault of the manufacturers. So is it your fault? Is it the fault of the manufacturer? And then the third view, especially in light of all this AI that's sort of mediating in these BCI devices, is a possibility for a new legal framework that's very different from what we have now, to create the possibility of some notion of hybrid responsibility. And that kind of idea that you could have that, especially once you get AI involvement, relates to things that we talked about earlier in AI and about the challenges of notions of fiduciary obligations for physicians when you have AI involved. It's very analogous to that, that when you start to have these sort of hybrid roles, allocating responsibility is going to be challenging for our traditional norms for how we think about moral responsibility. Okay, next set of issues are really the standard research ethics issues. So very standard things that should come to mind pretty early on in thinking about these sorts of things. The one that gets, of course,
this is more in the setting of when they're being developed and researched.
Correct, so rather than their use. That's correct. So the one that gets by far the most attention is informed consent, right? Automatically, that's the place you should go pretty quickly. So a lot of the patients who are availing themselves of BCI have one or another disability that may make it challenging or impossible for them to actually give informed consent. Somebody who's locked in, it may not be possible to carry on the kind of conversation you need to have to give informed consent. Having had to do capacity assessments of patients in the hospital who are like intubated or have other kinds of significant communication impairments, it can be very challenging to assess somebody's capacity to be able to make decisions and to see whether or not find out whether they want to give an informed consent or an informed refusal or and so on. Another concern about informed consent, in addition to its sort of technical challenges, are questions about whether or not it can even be done voluntarily, given how incredibly desperate some patients may wind up being. So patients who are heading down a slope towards being locked in, they've got advanced Parkinson's, they know it's just a matter of time, even with drugs they're forestalling the timing, but eventually those will stop being effective and they're heading towards a future that they may find too grim. And so, so that may undermine the voluntariness. This is at least an argument that people have made. There are other people who are skeptical of these kinds of arguments. We, after all, get consent from these kinds of people for procedures and other sorts of things. It's not clear why they couldn't give consent to research. There may be unrealistic expectations of benefit. That's a big one. And that really is a function of concerns about the overhyping of the technology. So people are very worried that the technology is, whenever you have something new like this, we saw this with gene therapy, which now actually finally at long last exists. But throughout the 90s and the first decade of the 21st century, there was so much hype about it and yet very little reality in terms of actual treatments. We saw the same thing with stem cells, all this hype about stem cells were going to cure everything. People were going to be able to walk again. Anyway, so worries that there may be hype.
Arguably, we're seeing it with AI and CRISPR right now.
Yes, exactly.
In fact, we're such in the middle of it that it's hard for me to even say that because I'm so excited about AI and CRISPR, but that's probably a sign that it's being hyped.
Yeah, that's exactly right. Well, everybody says that, right? So I remember talking to stem cell scientists who were like, yes, well, this is not like gene therapy. We're not going to overhype it, but we're going to cure everything in 5 years. It's just
What's
amazing.
so overhyped about curing every disease, David?
Yeah, there we go. So it's just very interesting. So we keep doing this over and over again, but especially for patients, we're giving informed consent. That overhype may create unreasonable expectations, which may in turn undermine the ability of them to give informed consent. And then one worry that we've talked about earlier that arises in this tech, as for everything else, the potential for incidental findings, that you may find things that are unrelated as you're going in there that you then have to disclose. And we've already talked about that earlier in the class. And one thing you should start to get a sense of is that there's overlap between the issues. There's sets of issues that you tend to arise for a lot of these technologies, and certain things that some of these technologies overlap enough that the issues can be quite similar. So incidental findings arise a lot in imaging technologies. They arise a lot in genetics and genomics, and there's a potential, since there could be imaging involved. So as you're doing the research on this and you're trying to figure out the placement of the devices, what if you find like a tumor in the brain? What if you find other sorts of things? So there will be incidental findings that cause challenges, and we've already talked in previous videos and in some of the readings that you've already read about some of those kinds of issues. The next set of issues are around privacy and security. In our article about wearables that Corolla and I wrote, we talked about imagined hacking to turn off somebody's pacemaker and that turning into a plot, which I guess it now has on TV shows or movies. Homeland. That's right, Homeland. Yeah. But here's the new one, a new version of the Manchurian Candidate, which if you have not seen this, it's a classic film with Frank Sinatra, I think, was in that, right? From a long time ago. But anyway, we're
going to start a Piazza thread on shows and movies that are excellent examples of BioE 131 conundrums. In fact, if somebody wants to go ahead and start that, please do.
So yeah, that'd be nice. So the idea is, what if you could hack somebody's BCI to get them to do things? So it's right, get somebody else to commit the murder for you, get somebody else to do something that you want them to do, or assist in a crime in some way, because you're using BCI to get them to do that. So maybe you've got somebody who's an accountant being assisted by a BCI device, and you hack into their brains so that you can then have
Cook the books.
so that, yes, or you could embezzle the money. Coming soon to a TV show or movie near you. And then there, aside from the possibility of hacking, there's just the general privacy concern that once you start mucking around with things that are like accessing the brain, you may inadvertently wind up giving somebody access to or knowledge of what's happening in their minds. And so the potential privacy implications of essentially public availability of your inner mental states is something that a lot of people are worried about.
You had a fancy phrase for that in one of the previous classes, cognitive something or other. Cognitive
liberty.
Liberty. Thank you.
Cognitive liberty. Yes, people are worried. There's just whole groups who are devoted to worrying about this. I don't mean just academics. I mean, there's like advocates, NGOs that are worried about cognitive liberty in the era of these kinds of technologies. The next set of issues are issues around justice. One thing that should have has come up periodically through the course that we should be thinking about is who's impacted by the technologies and what role do they play in the design process, and trying to find ways of bringing the people who are likely to be impacted to have those voices present, not just at the end when we say, here's this great thing we're going to give you, but to have them actually part of the design process so that it's responsive to their actual needs rather than the perceived needs by the people who are designing the technology. And that's, again, a refrain that you've heard a few times before during the quarter. There are some disability perspectives. There's worry that some disability perspectives may be excluded by the technology development itself. And so that's obviously a big concern. Access is, of course, a big one. Are we heading towards a world where if you have certain kinds of terrible disabilities, you have Parkinson's and you happen to be affluent, well, then that's okay. We have some things for technologies for you, so Parkinson's won't be anything you have to worry about. But if you should be poor, then no BCI for you, and then Parkinson's means you're heading down a pathway. What if we could do BCI to help address ALS? Is access going to be equal for these technologies, or is it going to exacerbate existing inequalities in terms of how these things are distributed? And of course, enhancement makes all of these justice issues much more pressing. If people who have access to BCI could have dramatic increases in their memories, hey, look, I just downloaded an entire encyclopedia. If that ever becomes possible to access the information much better as an enhancement, then again, unequal access to those enhancements could be highly problematic. Although, again, you can always turn that argument around and say that doesn't show that we shouldn't have BCI. What it shows is we should distribute it better and make it more available to the people who are less well off, so that they can make use of that and maybe do something to help overcome some existing disparities that exist. Very interesting. So Klein, who wrote one of the articles you read for today, has developed a very interesting twist on an interesting argument, which has to do with the timing of these devices. Because these involve surgeries in the brain, it's a very good chance that you will only be able to do this once, which means when you get a technology at a certain point and a device implanted in your brain, but then in 5 years there's a much better version out, you will be dated and your BCI may not be as good as people down the road. And so that's another really major justice issue, that early access may be harmful to the individuals. And so again, thinking about that distribution of who end up becoming the early adopters or forced to get the early ones versus people who get later versions. But that's going to be a problem that's going to exist potentially forever, because each new generation will wind up of device will wind up only being available to people who have not yet had surgery done on them, which is, I think, a very interesting issue. Other issues, we already mentioned that AI will be used to fill the gap between patient thought and action. and that this may exacerbate many issues around responsibility, but it also means that all the other AI issues around bias and problems around AI that we talked about earlier in the quarter will come into play. And then I'll just end with one last example of what the real world happens when you're when you have the real world use of these things in a commercial setting. A company that was sponsoring research went bankrupt. And so somebody who'd been having a lot of success with a BCI tool had to have it explanted because the company went belly up, and so it was no longer going to be supported. And so just think about how terrible it must be to have somebody who was very, very limited in certain ways, and the BCI was helping them to overcome their limitations. They've put in all this hard labor and work to be able to master the BCI to do those things, only to be forced to have it explanted. And I know in that particular case, there was a lot of, the person kept trying to put off the explant and tried to do it as long as possible, but they were essentially eventually forced to allow that to happen since it was not going to be able to be supported anymore by the bankrupt company. And that just highlights how you have to really think through all the implications of what happens when you start to go down the road, especially when you're doing this as research in the early settings. That was a whirlwind tour of the literature on ethics and BCI. So that's it. We've got a couple of nice examples of that in the readings, but that's the literature.
There it is. Thank you very much for coming to this module, and we'll see you at the next one.